Welcome to the deep dive. Today we're tackling a really critical twist in the gut. Volvulus.
That's right.
We've got some high-yield revision notes here, and basically our mission is to pull out the most crucial knowledge about this condition. We're talking definition, what causes it, who's at risk, how it messes with the body.
Right, the pathophysiology.
Exactly. And how to tell it apart from other problems, who tends to get it, what it looks like,
Clinical features.
how it's diagnosed, treatment, prognosis, potential complications, all the key stuff.
Everything you need.
So if you've ever felt like a knot in your stomach, imagine that amplified dramatically. Today, we're diving into volvulus to really untangle what happens when things in your GI tract take a seriously dangerous turn.
Right, so let's get straight to it. Volvulus, at its heart, is an abnormal twisting of a segment of your gastrointestinal tract.
A twist.
Yeah, and not just a minor kink, it's a full-on twist that has a couple of major consequences. First, it creates a physical blockage, right? Stopping food and fluids from passing through. Second, and this is perhaps even more critical, this twisting action squeezes the blood vessels supplying that segment. It cuts off or significantly reduces its blood flow.
Okay, so that sounds bad. Where does this usually happen?
Well, we commonly see this in the small intestine specifically. We call that sigmoid volvulus, or sometimes in the stomach, which is known as gastric volvulus.
Okay, so it's a complete, like a 360-degree twist.
Exactly. It's a complete loop of the intestine around its mesentery.
The mesentery, that's the tissue holding it in place.
Yeah, precisely. Think of it as the sheet of tissue anchoring your intestines to the back of your abdomen, and it carries all the vital blood vessels and nerves.
Got it.
And as you mentioned, while sigmoid and gastric volvulus are common, this twisting can actually occur in various parts of the GI tract. So the stomach itself, different sections of the small intestine, the caecum, the transverse colon, and the sigmoid colon.
Now, these revision notes also bring up something called midgut malrotation. How does that fit in?
Ah, yes. That's a really key piece of the puzzle, actually. Midgut malrotation is a condition where the entire midgut, which is a big chunk of your intestines, twists around the superior mesenteric artery.
A major blood vessel.
Very major blood vessel, yes. And this usually happens because of issues during the baby's development in the womb.
Developmental issues, what kind of things go wrong?
Well, very early on in pregnancy, the GI system starts out as just a straight tube.
Simple enough.
Right. But then over about 8 weeks, this midgut section undergoes this really complex process of rotation, and then it needs to fix itself, attach properly to the inside of the abdominal wall.
Okay.
Now, if there are any disruptions during this sort of developmental ballet, it can result in a narrower than usual mesenteric base. Imagine like a flagpole with a really small base that's much easier to twist over,
Yeah,
right?
less stable.
Exactly. This narrow attachment increases the risk of the bowel twisting around that central axis later in life, potentially leading to a volvulus.
So when we talk about what actually causes volvulus, the etiology, it sounds like it's not always simple.
That's right. The precise cause isn't always crystal clear. However, we know several factors can contribute.
Such as?
These include actual anatomical abnormalities that someone might be born with, or adhesions, the scar tissues inside the abdomen.
From surgery? You
Often
think?
from previous surgery, yeah.
Yeah.
They can stick organs together. Then there's chronic constipation, the malrotation we just discussed,
Right.
and even situations where the tissues in the intestinal wall are weaker than they should be.
And who is more likely to get this? What are the key risk factors we should be aware of?
There are a few consistent risk factors. Advanced age is definitely one, and so is chronic constipation, as I mentioned. If someone has had previous surgery on their abdomen, that also bumps up the risk because of those potential adhesions.
Right.
Intestinal malrotation, as we've covered, is a significant predisposition. And interestingly, certain connective tissue disorders and also neurological conditions that affect how the bowels move, like Parkinson's.
Exactly, like Parkinson's disease. They've also been linked to a higher risk of volvulus. We think this might be due to the altered muscle tone or peristalsis in the bowel.
Okay. Let's try to picture exactly what's going on inside the body when a volvulus happens, the pathophysiology. Walk us through that.
Okay, so picture that loop of intestine twisting around as mesentericattachment.
Right.
The immediate consequence is a physical blockage and obstruction. Food, fluids, gas, they just can't get through.
Okay, blockage first.
But at the same time, this twisting also puts pressure on those blood vessels within the mesentery. It reduces or completely cuts off the blood supply to that section of the bowel.
And that leads to?
Well, first it leads to distension because fluids and gas build up behind the blockage in that twisted loop.
Bloating.
Significant bloating, yeah. And if the blood supply is reduced or cut off for too long, the tissue becomes ischemic, basically. It's starved of oxygen.
Ischemic.
And if this carries on without any intervention, that tissue can actually die. We call that necrosis. Necrosis. Wow, okay. That sounds incredibly serious and like something you'd want to diagnose really quickly.
Absolutely critical.
So if someone comes in with these kinds of symptoms, severe abdominal pain, vomiting, what else might be going on? What's the differential diagnosis we need to think about?
Yeah, good question. The initial symptoms can definitely mimic several other conditions. We always consider a general intestinal obstruction first, maybe caused by adhesions or even tumors.
Okay.
Acute appendicitis and gallbladder disease, cholecystitis, they can also cause significant abdominal pain. And even more common things like gastroenteritis or irritable bowel syndrome, IBS, might initially present with some overlapping symptoms.
Right. IBS can cause pain and bloating too.
It can, though usually not as acutely severe or with the same red flags as volvulus.
And these notes list a really wide range of other possibilities, especially for maybe less clear-cut cases.
Exactly. Particularly in older children or adults who might have more long-lasting or vaguer abdominal issues, the list of potential diagnoses gets much broader. Well, you'd need to consider things like annular pancreas, colic, simple constipation, maybe duodenal tregia or duodenal leb, gastroesophageal reflux.
Wow.
Even Henoch-Schönlein purpura, hepatitis B, or Hirschsprung's disease. Then there's hypertrophic pyloric stenosis, an incarcerated hernia, intussusception, Meckel's diverticulum, necrotizing enterocolitis.
Keep going.
Yeah. Ovarian portion in females, pancreatitis, peptic ulcer disease, a perforated viscus like a hole in the bowel renal stones, sickle cell crisis, even a urinary tract infection.
Yeah, that is a huge list.
It really highlights how important it is to do a thorough assessment, doesn't it? You can't jump to conclusions. But, red flag symptoms like that sudden onset severe pain and especially bilious vomiting would definitely push volvulus higher up the list than something like IBS.
It sounds like a real diagnostic puzzle. Now, how common is volvulus actually? What's the epidemiology, say, here in the UK?
Yeah, the exact prevalence of volvulus itself in the UK isn't really nailed down. We know it's generally considered rare. But importantly, it can happen at any age. It does seem to be more frequent in older adults, though.
And what about the midgut malrotation link?
For midgut malrotation, we have slightly better figures. Estimates range from about 1 in 500 to maybe 1 in 2,500 live births in the UK.
That's quite a range. Is that because it sometimes goes unnoticed?
Precisely. That's part of the uncertainty. And while malrotation is often diagnosed in the first year of life,
Right.
it's really important to remember that it can actually present for the first time in adults too.
Good point.
It's also worth knowing that if someone has recurrent bowel obstruction, it's more often due to adhesions than, say, a volvulus happening again and again.
Okay.
The true number of people walking around with malrotation is likely higher because some individuals might have it their whole lives and never experience any symptoms at all.
Asymptomatic.
Exactly. However, we do know that the majority of malrotation diagnoses happen within the first year of life, with most of those actually occurring within the first month.
The neonatal period.
Right. But the key takeaway for us is that volvulus, whether from malrotation or other causes, can indeed show up at any age. And there are even these rare cases where people have had recurrent bowel obstruction specifically due to volvulus happening again after they've already had surgery for it.
Okay. So what are the key things then that might make a doctor suspect volvulus? What kind of clinical features are we looking for?
Well, the classic presentation of volvulus often involves pretty significant abdominal pain and distension, that feeling of the belly being really swollen and tight.
Pain and swelling?
Yeah. Patients will usually have nausea and vomiting, and they often report that they can't pass gas or have a bowel movement. Those are really suggestive signs of an obstruction.
Right, nothing getting through.
Exactly. In some cases, you might even see hematochezia, that's visible blood in the stool.
Okay.
More general signs of a bowel obstruction, like constipation and maybe not hearing normal bowel sounds when listening to the abdomen, would also likely be present. Sometimes patients might just present initially with constipation and abdominal bloating.
And what about malrotation specifically? Are the symptoms different there?
Yes, and this is crucial. In newborns, bilious vomiting, that's vomiting green fluid, green bile, is a huge red flag for malrotation.
Green vomit equals emergency.
Pretty much, yes. Needs urgent investigation. Other symptoms in infants can include problems feeding, not gaining weight properly, what we call failure to thrive,
Uh-huh.
loss of appetite or anorexia, constipation, and even bloody stools or brief pauses in breathing called intermittent apnoea.
Okay. And older kids or adults?
Older children might have episodes of vomiting that come and go, cyclical vomiting, or recurrent tummy pain. They might not be absorbing nutrients properly, leading to protein-calorie malnutrition, and in some rare cases, even issues with their immune system. And in adults, ongoing abdominal pain can be the main symptom if they have a previously undiagnosed malrotation.
What about if things are really bad? If the volvulus has been going on for a while or is particularly severe, are there more worrying signs?
Absolutely. Advanced volvulus can present quite dramatically. Sudden onset, often bilious vomiting. You might see signs that the body is under significant stress,
Nice.
like metabolic acidosis, raised lactate levels in the blood, lectotemia, decreased urine output, which is oliguria, low blood pressure, hypotension.
So, shocky signs.
Exactly, potentially leading to shock. Sometimes a doctor might be able to feel a distinct lump or mass in the abdomen. The abdomen itself might become acutely painful and very swollen, and you could see signs of peritonitis.
Inflammation inside.
Yes, inflammation of the lining of the abdomen indicating a serious problem like perforation. Patients might also pass blood or what looks like sloughed off dead tissue in their stool.
Grim.
Yeah. Other signs include a rapid heart rate, tachycardia, low blood volume, hypovolemia, and if gangrene has developed in the bowel, the patient could rapidly go into septic shock.
Those are definitely signs you wouldn't want to miss. Are there any handy ways to remember these key symptoms? Mnemonics, maybe?
Yes, there's a simple one for volvulus itself. Think of the V's. Vomiting, very painful abdomen, and no voluntary passage of stool or gas.
V's for volvulus.
And for malrotation, especially in newborns, just hammer home bilious vomiting. That green color is the crucial warning sign you cannot ignore.
Got it. Green vomiting bad. Okay, so someone presents with these kinds of red flags. What investigations are typically done to figure out if it actually is volvulus?
Right. The initial investigation is often an abdominal X-ray. This can show general signs of a bowel obstruction, or sometimes, in the case of a sigmoid volvulus, it reveals a really characteristic coffee bean shape.
The coffee bean sign, I remember that.
Exactly. It's the distended loop of bowel. Then, a CT scan gives us much more detailed pictures. It lets us see the bowel walls, the twist itself, and helps assess how severe things are.
Okay, CT for detail.
And blood tests are also really important. We need to check for dehydration, look at electrolytes, and check for signs of infection, like a raised white cell count.
And how do we get to a definitive diagnosis? What really confirms it?
Well, volvulus is often strongly suspected, if not diagnosed, based on those X-ray findings, especially that coffee bean sign for sigmoid volvulus. A caecum volvulus might just show more general signs of a small bowel obstruction on X-ray.
Right.
Additional blood tests, like a full blood count and inflammatory markers like CRP, can help us gauge how unwell the patient is. Radiography, the X-rays, are really key for identifying if there's a bowel obstruction in the first place.
What about contrast studies?
Contrast studies, yes. That's where we give the patient a special liquid to drink or introduce it via the rectum and then take X-rays. These can really help visualize the twist and confirm a volvulus, often showing a very specific bird's beak pattern where the contrast stops abruptly at the twist.
Bird's beak, okay.
Ultrasound and CT scans are both really useful for confirming both malrotation and volvulus.
How does ultrasound help?
On a color Doppler ultrasound, we might see something called the whirlpool sign.
Whirlpool.
Yeah, where you can actually see the mesenteric blood vessels swirling around each other at the point of the twist. It's very suggestive of malrotation with an active volvulus.
Cool sign. And CT.
CT scans can also show us abnormal relationships between the major blood vessels, like the superior mesenteric artery and vein, and the position of the duodenum, the first part of the small intestine. These positional changes are typical of malrotation.
Makes sense.
It's worth noting, though, that while ultrasound can sometimes be the first test, especially in children because there's no radiation,
Right.
it might not always be able to completely rule out malrotation if the signs aren't obvious.
Okay. The notes give an example question. A young infant presents with persistent bilious vomiting. Which initial imaging modality would be most helpful in evaluating for potential malrotation? What's the answer there?
Good question. The most helpful initial imaging would likely be either an ultrasound looking for that whirlpool sign,
Uh-huh.
or perhaps more definitively, an upper GI contrast study.
Why the contrast study?
Because that can directly show us if the duodenum and the duodenojejunal flexure, where the duodenum meets the jejunum, are in an abnormal position, which is a classic hallmark of malrotation. It directly visualizes the anatomy. So either US or upper GI contrast would be the go-to initial tests.
Okay, we've found the twist. Now, how do we untangle it? What's the management for volvulus?
Right. The main treatment, the definitive treatment for volvulus is surgery.
Surgery needed.
Almost always, yes. The goal is twofold. Relieve the obstruction, and crucially, restore that compromised blood flow to the affected part of the bowel as quickly as possible.
Makes sense.
Now, the specific type of surgery depends on where the volvulus is located and how severe it is. For example, sometimes a sigmoid volvulus can initially be treated, or at least decompressed, using a rigid sigmoidoscopy.
Putting a scope up.
Exactly. A tube with a camera is used to gently try and untwist the bowel from below. However, this often provides only temporary relief, and surgery to remove that section of bowel is frequently needed later to prevent it from happening again. For something like a caecum volvulus, which involves the beginning of the large intestine, a right hemicolectomy removing the right side of the colon is a common procedure.
And before surgery?
Absolutely vital supportive care. Intravenous fluids to rehydrate the patient and correct any electrolyte imbalances, and antibiotics to cover potential infection or translocation of bacteria from the compromised bowel.
Okay. What about if someone is found to have malrotation, incidentally, like on a scan for something else, but they aren't having any symptoms? Does that always need surgery?
That's a really interesting and slightly debated point. Traditionally, asymptomatic malrotation, especially if found in an older child or adult, might sometimes be managed conservatively, just keeping a close eye on them, maybe with some advice about symptoms to watch for.
Just watch and wait.
Kind of. Maybe using decompression if needed, if mild symptoms arise. However, there's increasing evidence, particularly in children, suggesting that even if they don't have symptoms, preventative surgery might be the best option.
Why is that?
Because the risk of a sudden catastrophic volvulus happening at some point in the future is always there with malrotation, and the consequences can be devastating. So many surgeons now advocate for elective surgery to fix it.
Okay. And what's the standard surgical procedure for volvulus in general? The notes mention something called Ladd's procedure.
Yes, Ladd's procedure is the classic operation, especially when volvulus is related to malrotation. It's often the preferred surgery.
What does it involve?
Essentially, the surgeon manually untwists the small intestine, usually by rotating it counterclockwise. Then, crucially, they broaden the base of the mesentery by repositioning the caecum over to the left side of the abdomen and straightening out the duodenum along the right side. They also often remove the appendix at the same time.
Why remove the appendix?
Because its position will be abnormal after the Ladd's procedure, potentially making appendicitis difficult to diagnose in the future.
Ah, okay.
And there's also a laparoscopic version of Ladd's procedure now.
Keyhole surgery.
Exactly, using smaller incisions, which can lead to fewer adhesions down the line and less scarring compared to the traditional open surgery.
So Ladd's is the main approach.
For most cases of volvulus related to malrotation, yes. And laparoscopy is often suitable, especially maybe in children presenting with an acute abdomen where you want better cosmetic results and potentially less postoperative pain.
Ladd's to untwist. That's a good one to remember. So after treatment, what can patients expect? What's the outlook? The prognosis?
The prognosis really hinges on a few key factors. Firstly, how quickly the diagnosis was made and treatment, usually surgery, was started.
Timing is critical.
Absolutely. Secondly, the extent of bowel damage. Was there any necrosis, any dead bowel that needed to be removed? And thirdly, does the patient have any other significant underlying health conditions?
Okay.
Generally, early intervention and surgery make a huge difference and significantly improve the chances of a good outcome.
Good news.
But conversely, if treatment is delayed, it can lead to really serious complications and, unfortunately, an increased risk of mortality.
So speed matters.
Immensely. It's also important to remember that even with prompt diagnosis and treatment, malrotation itself carries this inherent risk. It can sometimes lead to sudden and severe problems like extensive bowel ischemia and necrosis, which can sadly be fatal even if managed quickly.
A sobering thought. What kind of specific problems or complications can arise from volvulus, either before or after treatment?
Well, the most immediate and serious complication of a volvulus that isn't treated quickly is the bowel losing its blood supply and the tissue dying, that's the ischemia and necrosis we talked about.
Right.
This dead bowel can then rupture or perforate, spilling gut contents into the abdominal cavity. That causes a dangerous infection called peritonitis,
Peritonitis.
which can rapidly progress to sepsis, a life-threatening body-wide response to infection.
That's it, okay.
And if a large section of the intestine has to be removed surgically because it's died, the patient can end up with short bowel syndrome.
Short bowel syndrome.
Yeah, where there isn't enough functional intestine left to absorb adequate nutrients and fluids from their diet. This can cause long-term problems.
And what about if someone has a volvulus that maybe twists and untwists?
Right, so if someone has untreated midgut volvulus that persists, even intermittently, it can lead down that same dangerous path. Intestinal ischemia, the lining of the bowel dying, which is mucosal necrosis, and potentially sepsis. Without prompt treatment during an acute episode, it can lead to perforation, peritonitis, and potentially death.
Okay.
If someone has more chronic intermittent volvulus, where it twists and untwists, the main complication might be malabsorption, not getting enough nutrients, and they might experience these odd alternating periods of constipation and diarrhea.
And after surgery, any specific complications, especially with that short bowel syndrome?
Yes, definitely. If someone develops short bowel syndrome after a large resection, the main complications often relate to managing their nutritional needs, which frequently requires long-term intravenous feeding or parenteral nutrition.
5 feet.
Right. And that comes with its own set of risks, like infections related to the central line used for feeding, potential liver problems from the IV nutrition itself, and in children, difficulties with growth and development.
Lots to consider there. We have another example question here. What is a major long-term complication to be aware of in patients who have undergone significant bowel resection for volvulus?
Based on what we just discussed, the key long-term complication we absolutely need to be aware of in those patients is short bowel syndrome and all the associated nutritional challenges and potential reliance on parenteral nutrition.
Short bowel syndrome. Got it. Well, that's been a really thorough look at volvulus. So just to summarize the key takeaways, it's this dangerous twist in the gut.
A critical twist.
Yeah, that can have really serious consequences if it's not recognized and treated quickly. Especially that bilious, that green vomit in infants. Huge red flag.
Absolutely. Don't ignore green vomit.
And surgery is usually needed to correct the twist, check the bowel viability, and get the blood flowing again.
Exactly right. Prompt surgical intervention is key in most cases.
Yeah.
It really highlights how something that seems like a, relatively simple anatomical issue during development,
Like the bowel not rotating correctly,
can have such profound and potentially life-threatening consequences later on in life.
it makes you think, doesn't it? Consider how a seemingly small anatomical anomaly during development can have such profound and potentially life-threatening consequences later in life. What other seemingly small factors might have similarly significant impacts on our health? Something to ponder.
Indeed.
If you want to really solidify your understanding of high-yield medical topics like volvulus, be sure to check out MSRA.com.
Great resource.
And for even more free resources to help with your learning and revision, head over to freemsra.com. Thanks for joining us for this deep dive.